So George Adams, interventional cardiologist, Rex Hospital. It's my pleasure to be with y'all today. I'd like to thank Craig Walker and the NCVH Digital Education Series for inviting me to give this lecture. Today we're going to discuss shockwave lithotripsy, concept and results. These are my disclosures, which are not relevant to this presentation. So intravascular lithotripsy, to treat both peripheral vascular and cardiovascular calcium, has been around for years. In fact, there's 30 years of safety data in kidney stone treatment. These sonic pressure waves preferentially impact hard tissue, disrupt calcium, and leave soft tissue undisturbed. Cardiovascular lithotripsy are miniaturized and arrayed lithotripsy emitters for localized lithotripsy at the site of vascular calcium. And these are the peripheral IVL catheters, as you see here on the right. The shockwave system consists of an IVL generator. It's compact, rechargeable. It has a connector cable, which is simple and easy to attach. Has an IVL catheter, which is an over-the-wire system, 0.14-inch compatible, and it works just like your standard PTA technique. As you can see here to the left, this is a close-up of the actual balloon and the lithotripsy emitters. There are two shockwave catheters. One is above the knee, which is the M5, and it can treat a diameter of vessels from 3.5 millimeters up to 7 millimeters. And then the below the knee catheter, which is the S4, which can treat a diameter of 2.5 to 4 millimeters. The S4 is 5 French compatible, has 135 centimeter working length, and the M5, the above the knee, is either 6 French or 7 French and has 110 centimeter working length. This is a depiction of exactly how it works. As you can see, the energy comes through the cable. You get these sonic pressure waves. They travel through the vessel once they are delivered at an effective pressure at about 50 atmospheres. As you can see to the top left, it's low atmospheres. Our goal here is not to cause barotrauma, but to crack the calcium. It's a localized effect, and it can affect both intimal and medial calcium, as you see. This is another depiction of the sonic pressure wave forms. As you can see, it's a fluid-filled balloon in number 1. Number 2, you get these sonic pressure waves. And as you can see below, this is the actuation of a single pulse, causing these waves to go through both this intimal and medial calcium. So what is this impact of cardiovascular calcium? As you can see here, these are OCT images, and you can see how we get these graduated cuts in these plaques, these breaks in the plaque, such that as the balloon expands, you don't get these spiral dissections, and it hopefully prevents vessel recoil. To the left is coronary artery depictions, and to the right is peripheral arterial depictions. There's a broad range of IVL applications. So the types of calcium, whether it be eccentric or concentric, a multitude of disease states, cardiovascular, peripheral arterial disease, and at the worst end of the spectrum, critical limb ischemia. A whole host of vessels, any of which have calcium, such as mesenteric, renal, femoral to popliteal segments, infrapopliteal segments, iliacs, common femoral artery, and also coronary. It could be either a standalone therapy or for vessel prep, an alternative to surgery, and can aid in transfemoral access, especially for structural heart procedures. There's a host of data, as you can see here, going from SFA pop lesions, all of which severely calcified, to just general peripheral arterial lesions, common femoral artery lesions, structural heart to affect iliac and femoral lesions, and then again below the knee, looking at not only the effects on calcium in terms of preventing the safety or having the safety and efficacy of keeping the vessel open and preventing adverse events, but also in terms of recoil, which is a study that's currently enrolling patients, as you can see here to the far right. Again, a whole host of vascular beds that can be treated with intravascular lithotripsy. As you can see, starting high, celiacs, mesenterics, renals, going to your transfemoral access, common femoral artery iliacs, SFA pops, and then up below the knee, especially in those critical limb ischemic patients. When we focus on critical limb ischemia, remember 3 epidemics currently are happening, not just in the United States, but around the world. People are getting older. The fastest growing age population in the United States are those older than the age of 65, specifically those older than the age of 80. 1 out of 4 Americans over the age of 65 have diabetes, which increases your inflammatory process, causing vascular disease. The #1 cause of kidney disease is diabetes. If you put all of these demographics together, it causes the worst of worst vascular disease. For peripheral arterial disease, it causes multi-level chronic total occlusions, and typically the plaque morphology is calcium. This is an example of a below-the-knee lesion. Again, a calcified small vessel, typically it's occluded. You have long, tortuous lesions, again, calcium. And then below the knee especially, the concern is dissections, inability to cross these lesions. They don't expand well. And of course, you get acute recoil, which we'll go into in a minute. When we look at the challenges of calcium, right? If you look at in the middle, control patients versus claudicants versus critical limb ischemic patients, in the critical limb ischemic population, the calcium burden is higher. When you look at amputation-free survival, it is less when you have calcium in the picture, as you can see here to the far right. Medial calcium, comparing above the knee, medial calcium is more prevalent in below the knee vessels, as you can see here in this graph. The dark blue is the intimal calcification, and the bright blue is the medial calcification. This medial calcification causes arterial stiffness, lack of expansion, and ultimately acute failure, restenosis, recoil, and complications. Remember, I mentioned a second ago in regards to recoil, Bowman and Baumgartner did a very elegant paper. And what they did is they just looked at plain old balloon angioplasty treatment below the knee. 97% of the vessels had greater than 10% recoil. In fact, if you waited 15 minutes, there was approximately a 30% recoil compared to immediately after the procedure. Why? Because this intimal medial calcification, again, causes this arterial stiffness, and you get this vessel recoil and ultimately restenosis. There are several current technologies in calcified lesions, but currently none are perfect. If you look at just the standard of care, balloon angioplasty, it produces significant complications and suboptimal outcomes. With drug-coated balloons, there has been no patency or amputation benefit versus plain old balloon angioplasty in approximately 5 randomized controlled trials. And most of these excluded significant calcium. Also, drug uptake is limited by medial calcium. When we look at scaffolds, stents in particular, in short lesions, if you look at the Paradise data, there was improvement in short lesions with drug-eluting stents, but stenting limits future treatment options and is typically reserved for bailout complications. If we looked at atherectomy, it reduces but does not eliminate serious complications. The verdict is not out in terms of whether it affects medial calcium. It's considered an improvement over balloon angioplasty for acute outcomes, but there's no global standard for atherectomy. If we look at medial calcification, this is some data to show that IVL actually affects it. And this was presented by Andrew Holden at Lincoln, which he did a sub-study. And as you can see by the OCT, you get this breaks not only in the intimal calcium, but also in the medial calcium, hopefully preventing that spiral dissection and that recoil. When we look at specifically the DISRUPT BTK trial, these are the patient demographics and angiographic findings. Again, this was an older population. Again, multiple comorbidities which predispose them to vascular disease, such as an older age, diabetes, hypertension, hyperlipidemia, and renal insufficiency. The majority of them were Rutherford class 5 at 75%. And as you can see, the distribution of tibial vessels that were worked on in the Disrupt BTK trial. The reference vessel diameter on average was 3.2 millimeters with a lesion length of 52 millimeters. All of them had moderate to severe calcium. The percent diameter stenosis on average was about 73%. When we look at the safety and efficacy or the outcomes of the study, the primary safety endpoint major adverse event rate at 30 days was nil, and the primary effectiveness endpoint, the acute reduction, was about 46.5%. The post-IVL residual stenosis of less than 50% was achieved at 100%. As you can see here to the right, the diameter stenosis post-procedure was about 26%, and there were very few adverse outcomes, with only 4.8% of the population having dissection. There was no perforation, distal embolization, thrombus, no reflow, or abrupt closure. When we look specifically at the device that we use for below-the-knee CS4, remember, it's got a hydrophilic coating, it's 5 French compatible, 40 millimeters in length in terms of the balloon, very low crossing profile. We typically try to size the balloon to the vessel at 1.1 to 1. And so this would be the sizing from a vessel size of 2 up to 3.5 millimeters and the balloon diameter that goes with it. This would treat lesions or vessels that would extend from the popliteal all the way to the dorsalis pedis. This is an example going back to that idea of recoil. In terms of what Bowman and Baumgartner showed, this was a patient that, as you can see, had critical limb ischemia, as a 50-year-old gentleman, multiple comorbidities, had critical limb ischemia, as you can see. Ultimately opened up the anterior tibial, both from an antegrade and retrograde approach with plain old balloon angioplasty. And as you can see here to the far right, had a really nice outcome with direct inline flow all the way to the foot through the anterior tibial. Now, what I did is, as you can see here by this graph, I put a ruler on the leg, and that's the reference points from 57 to 69. And then what I did is I performed IVUS immediately after the procedure using balloon angioplasty. And then I did a repeat IVUS at 15 minutes, as you can see here in the middle, and then at 30 minutes, as you can see here to the far right. At 30 minutes, what you see is that there was a recoil in all distributions of this lesion, ranging from 6% at the most minimal to a high of about 40%. So that's very interesting. So ultimately, we don't, as operators, even realize this unless we wait to watch to see if the vessel recoils. This is an example of intravascular lithotripsy. This is a 78-year-old gentleman, typical comorbidities, presenting with a medial plantar wound which is not healing. So ultimately, I try to open up the posterior circulation. I think everyone can appreciate that this gentleman has significant disease in the TP trunk, the ostium of the posterior tibial, and the proximal segment of the perineal. So what I did here is I used a 3/0 by 40 S4, and I started off at the level of the posterior tibial, performed therapy in this region. Then I pulled the IVL back and performed therapy at the level of the TP trunk. And then what I did was I pulled my wire back, redirected it down the perineal, and then advanced the intravascular lithotripsy shockwave device to the perineal and performed therapy there. This was the outcome. As you can see to the left, this is what we started with. And to the right, now we have good inline flow to the posterior distribution, ultimately improving flow to the wound and ultimately healing the wound. In summary, critical limb ischemia is a growing problem in patients with peripheral arterial disease. Calcification, specifically medial calcification, is common in critical limb ischemia and leads to worsened outcomes. Treating calcified below-the-knee lesions continues to be a challenge. There's limited data currently for these calcified lesions. We know that balloon angioplasty tends to have higher rates of dissections and need for bailout stenting. Drug-eluting therapies have promise but have not shown improvement in clinical outcomes below the knee. Atherectomy reduces the need for bailout stenting, but risk of dissection and embolization remains a concern for many. IVL is designed to treat both intimal and medial calcium, allowing vessel expansion with minimal recoil and decreased occurrence of flow-limiting dissections. Acute infrapopliteal results are safe with minimal vascular complications, including no perforations or clinically significant embolization. Additionally, 30-day infrapopliteal safety results report no major adverse events, including target lesion revascularization or amputation in disrupt BTK. Thank you very much for having me tonight. Have a wonderful evening.